A very warm evening to everybody and welcome everybody to the Wincars Lipid Symposium. This is going to be an extremely scintillating evening filled with very versatile discussions. We're going to be having discussions about the international and the Indian guidelines also about lipids. We're also going to be looking at sessions on dyslipidemia in women, dyslipidemia in the pediatric population, and also going to be discussing about the new agents on the block, the PCSK9, the bempedoic acid. What is their role in the current management scenario of people who have dyslipidemia? We will now hand over the proceedings to our organizing chairperson, Dr. Hema. Dr. Hema.
Yeah, it is my privilege and my honor to be organizing this meet on behalf of Wincars, and I thank all the organizing committee people for helping me out. And it was they gave me a couple of options, and lipid was one which caught my attention. And I was speaking to one of my mentors, and she was telling me lipid was not the first agenda when they started out in cardiology. So, but right now, today's need of the hour is know your numbers and know your cholesterol levels. And so we thought that this lipid session would be a good session to start off with. So the first session, we have kept it as...
So to introduce Dr. Hema, who's the organizing secretary of today. She's very fond of, singing, dancing, is a very great mother of 2 kids. And of course, she's an associate professor of cardiology at Mysuru. So all over to you, Dr. Hema.
Thank you, ma'am. Thank you very much. So I think without much delay, we will get back into our symposium. And the first session is what's in the guidelines. And I'd like to call upon Professor Prabhavati to chair this session. And Professor Prabhavati is my teacher, and she is an eminent professor of cardiology in Sri Jayadeva Institute of Cardiology, Bangalore. And she has been teaching, I think, most of us people who are already in cardiology now. And ma'am, I hand over the mic to you and the session. Thank you so much.
I should congratulate Dr. Hema for this wonderful symposium on lipids, and I thank her for being the part of this. We will start the program. I'll first introduce the speakers. First speaker is Dr. Rajani Sharma. She's a senior consultant at Delhi Heart Lung Institute. I'm proud to say that she was one of our best outgoing students from Jayadeva Institute. She has vast experience in various interventional procedures, and she has a lot of presentations to her credit. Hello, Rajni. How are you?
Hello, ma'am. Good evening, ma'am. So happy to see you after long years, no?
Yeah. Nice to see you. Okay, next speaker is Hema Rath. We'll come back. She's a consultant interventional cardiologist and assistant professor at NRS Medical College, Kolkata. And she also, I know her from her MD days, and she's a very expert interventional cardiologist. We have 3 panelists in this session. Dr. Veenu, she's interventional cardiologist at Apollo BGS Hospital, Mysore. And Lakshmi Shetty, he's our own staff. She's associate professor in Jayadeva Institute of Cardiology. And Dr. Kshamata Kerudi, he's cardiologist at Kerudi Heart Hospital at Bagalkot. So
how are you, ma'am?
I'm good. Kshamata, how are you? Nice to see you all after a long time.
Good evening, ma'am.
Yeah. Okay, I think we'll start the first talk. Dr. Rajani, are you ready?
Yes, ma'am. I'll share my screen. Yes, ma'am, I'm ready.
Okay, so Rajani will be speaking on
guidelines, ACC guidelines.
Guidelines, lipid international guidelines, a focus on ACC-AHA guidelines. So I hope
yes, ma'am.
stick to the time so that we'll have some time for the discussion at the end.
Yes, ma'am. My slide is visible?
Yes, it's visible.
Yes.
Yeah. Go ahead.
So, good evening, all my teachers, my colleagues, and I am really thankful for giving this opportunity and interacting with you, eminent cardiologists, women cardiologists all over the India. So the topic today given to me is discussing about the ACC-AHA guidelines, and I have clubbed both 2018 guidelines came regarding management of blood cholesterol, and then 2019 guidelines has come for primary prevention of cardiovascular diseases. So over the years, from 4 or 5 decades, we are using these lipid lowering agents, most commonly statins, that is inhibiting the rate limiting step HMG-CoA reductase, and we have found in so many years that lower the value, better will be the reduction of atherosclerotic cardiovascular diseases in future for that particular population where it has been like given, seeing the risk stratification of that particular patient. So I would be rather talking for all these lipid years and how we have achieved the mortality and morbidity benefits with treating these lipids by statins basically. So going to the primary prevention first. So the recommendation says that in adults 40 to 75 years, we have to generally calculate the 10-year atherosclerotic cardiovascular disease risk in that population. And there are online calculators for that, considering for that particular race and sex. And we take out this 10-year risk in those population before going ahead for deciding whether this person should be given statin therapy or not. So when we calculate this PC score, we stratified into the 4 categories, like low risk, where there is a risk of less than 5% in 10 years to have atherosclerotic cardiovascular disease, borderline, intermediate, and then high risk group. So it is quite clear with all the trials then that who are falling into the low risk below 5%, there is no need to give statin therapy, and just a healthy lifestyle or eating, diet, and other social factors could be managed well, and there would be no statin required. But it is also clear that when it falls towards high risk group, that is more than 20% risk of atherosclerotic disease in next coming 10 years, then we have to start with high intensity statin to overcome that risk. But what about this intermediate and borderline risk group? So in such scenario, we have to further consider certain risk enhancing factors to further decide whether this particular patient group would be needing statin therapy to prevent cardiovascular events in future. So if sometimes after seeing these risk enhancing factors, certain times we are, especially in certain population like young females, just they are 42 and not having typical atherosclerotic risk disease factors, we are not even clear for statin therapy in certain situation. In that scenario, we can go for coronary artery calcium scoring, and we could decide upon seeing the Agatston score, like whether this person should go for statin therapy or not to prevent atherosclerotic disease. All these factors should be considered in primary prevention. So as I said, for the borderline and the intermediate risk groups, we have to look for the high risk, this risk enhancing factors for deciding upon the statin therapy. In that, we have family history of premature atherosclerotic cardiovascular disease and primary hypercholesterolemia, where we are always getting LDL levels of more than 160, and then metabolic syndrome, chronic kidney disease, where eGFR is falling between 15 to 60. Chronic inflammatory status conditions like psoriasis, SLE, rheumatoid arthritis, HIV. Then history of premature menopause in female before age 40, and now it has like quite come up, seeing these like cardiovascular diseases being common in female. So they have come up like certain situations like gestational diabetes, gestational hypertension, and preeclampsia has come up with a higher cardiovascular disease in such young female groups. So we have to consider while deciding statins in female group. Similarly, we calculate and see the biomarkers also. If we are getting triglycerides more than 175, HSCRP more than 2, and lipoprotein B more than 130, and lipoprotein A little a more than 50, and ankle brachial index more than 0.9. So all these we consider in the intermediate and borderline risk group to further stratify our strategy regarding statin management. So as I said, when we are not clear with these risk enhancers also while deciding for statin therapy, then we may need to take help from coronary calcium artery scoring, and then we get the scores as 0, then we are quite clear this person doesn't need statin therapy. And if this score falls between 1 to 100, and especially if the patient age is more than 55, so we have seen that statin therapy would benefit this person for preventing future cardiovascular events. And if the coronary artery calcium score comes more than 100, then definitely these patients have been found benefit with statin therapy. So this is the overall primary prevention slide, and it looks quite busy, but I think understanding this slide would give a very clear picture like how we should go about for primary prevention in certain population. So if the person has, on the right side top, we could see class 1 recommendation. The person has LDL cholesterol more than 190. So directly that person falls into high risk group, and we have to go for high intensity statin. High intensity statin means we have to reduce the LDL level from baseline to more than 50% down, and the statin would be required in high dose, that rosuvastatin from 20 milligram to maybe 40 milligram, and atorvastatin from 40 to 80 milligram. In such scenario, if person is diabetic, then it is a high risk group, and diabetic person would fall into at least moderate grade reduction of intensity. Moderate intensity statin therapy would be required. So in diabetic as well as LDL more than 90, we need not to calculate this risk calculator, as I explained before, these 4 groups. So we go ahead with the statin management. But if the LDL level falling between 70 to 190 and age group is 40 to 75 years and patient is non-diabetic, then we calculate this risk score, and according to this we go for statin management. As I said, low risk we don't need to give statin therapy. High risk, more than 20% risk, we straight away go with statin therapy to reduce the LDL level more than 50%. And this borderline risk group we further stratified by considering high risk enhancers, as I said, written on this cartoon on the left side, the whole chart, as I said. Then we decide for statin management. Intermediate risk, again we calculate risk enhancers or sometimes the coronary calcium score, and we decide whether to go about with moderate intensity statin in such group or not. Similarly, as I said, diabetes, LDL more than 190. So these are high risk groups. So we have certain very high risk group where they have very high risk to develop future cardiovascular events. In that, the statin management is even more aggressive than high risk group. So those people who already have atherosclerotic cardiovascular event and they have repeated events in the form of repeated MI or any PAD or associated cerebrovascular events. So such multi events of cardiovascular damage would be considered very high risk group, and we have to go even more aggressive in such patients, and we have to sometimes combine statin therapy with other modalities of lipid reduction so that we achieve our LDL level even lower and lower. So high risk groups conditions are there, like age more than 65, then genetically heterozygous familial hypercholesterolemia, which we see in younger age group, maybe below 40 years, or sometimes homozygous manifested in children only. So that will be discussed later. Diabetes, hypertension, CKD, smoking, and persistent LDL more than 100, and history of heart failure. All these are high risk conditions. If we have more than 2 high risk conditions, then that person would fall into very high risk group, and there we have to manage such patients very high and very aggressively for reducing the LDL levels even below 55. So as I said, diabetes itself is a high risk, and we directly go for moderate intensity LDL reduction in such patients. If for diabetes, we have separate risk enhancers, like if type 1 diabetes more than 20 years or type 2 diabetes more than 10 years, or if albuminuria, these are the risk markers in diabetic patients having CKD established, retinopathy, neuropathy, or PAD established. If these factors are there more than 2, then that diabetic patient itself shifts from high risk to very high risk status. And there we have to consider even more lower LDL levels and combine therapies also for lipid reduction in such scenario. So this is a slide regarding secondary prevention, where the patient is already having cardiovascular event, and how we prevent further events in such patients. So as I said, if they had just one event of atherosclerotic cardiovascular disease, they are high risk patient. And if the age is below 75 years, we have to do treatment with high intensity statin, where our goal is to reduce LDL level more than 50%. And if some problem patient is intolerant to statin therapy, then definitely we can use moderate intensity statin, and we can combine this with ezetimibe and achieve our lipid levels more lower down. If the age is more than 75 years, then generally we have seen like Indian population and especially female doesn't tolerate that high dose statin. And then in such scenario, even we can go with moderate intensity statin therapy in such scenario. And even we can use ezetimibe and now newer agents like bempedoic acid to come down the cholesterol levels in such groups. If the patient with one cardiovascular event had another PAD or cerebrovascular event and they fall into very high risk group, then high intensity statin definitely we start, and we will look for the LDL levels, and definitely it has been dropped down to more than 50%, but still if we count the lower level and if it is still being more than 70, then definitely we have to consider other regimes also. Then first recommendation is to combine with ezetimibe, and if adding ezetimibe also we are not achieving LDL below 70, then definitely we have to consider in such very high risk patient for PCSK9 inhibitor for bringing down the LDL level to around 55 or below. So apart from this, there are routine like other social factors and lifestyle changes what we can bring down. Our lipid level should always be considered. Diet has been important factor in that. We have to see we are not taking saturated fats, take polyunsaturated, monounsaturated fatty acids, and trans fatty acids should not be taken, and all these factors should be considered. We should have more vegetables, fruits, legumes. Healthy eating should be inculcated almost, I think, all age groups consideration regarding this management for atherosclerotic disease. Then next important factor is a social, like getting sedentary lifestyle everywhere now. Main problem is diet may be managed, but there is no activity most of the time. So we have to encourage all the population group, whether it starts as early as from childhood itself, that everybody should be habitual of playing some sport, and they do 150 minutes of per week exercise of moderate intensity.
Excuse me, Rajni, can you
Yes,
summarize? Time
yes,
is up.
yes, then exercise, I think, need not elaborate much, ma'am. Then diabetic patients, we have to see like glycemic control is taken properly into taken care, and hypertension, as the ACC says that 120/80, below 120/80 is optimal, and those who have stage 1 hypertension, we calculate risk here, and if the risk is falling more than 10%, we have to consider medical management even in stage 1 hypertension where systolic is more than 130. So stage 2 hypertension, we directly go for medical therapy for controlling hypertension. Tobacco abstinence has to be enhanced in such population. Aspirin use nowadays, they say that low dose aspirin might be considered for primary prevention. in selected groups only, where the atherosclerotic cardiovascular risk is coming very high and the bleeding risk is coming low. Otherwise, routine use of aspirin is not encouraged nowadays. The triglycerides, similarly, as we are always targeting the LDL, but triglyceride has also to be looked upon. If it is coming more than 175, that is a moderate hypertriglyceridemia. Generally, triglyceride, we know it is due to secondary factors. All those has to be controlled, like diabetes, overweight, nephrotic syndromes, etc. If it is falling into severe hypertriglyceridemia, where it is more than 400 and 500, we need to consider for statin therapy in such scenario. And if it is more than 1000, then omega-3 fatty acids and fibrate should be considered. So recommendation says that female patients, as I said, so premature menopause and gestational.
Can you summarize?
Yes, ma'am.
If time is up.
I would, yes, ma'am. Then females now should be considered. I think that topic would be covered, and newer agents, as I said, these also would be dealt later on. PCSK9, vampinuric acid, and monoclonal human antibodies has come for like a genetic familial hypercholesterolemia. All these would be considered. So I think this case, then I would skip, ma'am. One example I would taken just. So I think will conclude here, and I think enough of time I have taken, but some wisdom would have got, I think, with these slides.
Okay. Rajani, thank you for that excellent presentation.
Thank you.
Yeah, we'll have some questions at the end if time permits.
Yes, ma'am, yes.
Okay. We move on to the next speaker, that is Dr. Hema Rath. She'll be talking on Indian lipid guidelines. Hema, are you ready?
Yes, ma'am. I'll just share the screen. Good evening, ma'am. How are you?
Good evening, Hema. I'm good. How are you?
Thank you.
Nice to see you.
I'll just share the screen. One.
Yeah. Go ahead.
Good evening, my seniors and my dear friends. Today I'll be speaking on Indian lipid guideline. Though there were, as Rajni spoke about international guidelines, it is all done with the RCTs and their class of indications and other things. Why do you think we still need to have a lipid guideline in India? So this is the WHO, who estimated 50% cardiac patient worldwide to be Indian by 2020. India will be said to be a heart disease capital of the world. So what is the another reason is there are tsunami of premature heart deaths in India, which are varied from that of the Western population. That is between 30 years of age till the 50 years, and more so in the younger age group. So what did the Indian experts feel about it? Why should we have an Indian guideline? So compared to the other ethnic groups, Southeast Asia and high prevalence of we have a higher prevalence of atherogenic dyslipidemia, higher prevalence of traditional risk factors, and risk of younger age having severe disease and poorer outcome. And we have lack of awareness on CAD prevention. The dietary factors are different. The physical inability to secondary to the inactivity, secondary to rapid urbanization, all these will give a reason why we should have an Indian guideline. The pattern of dyslipidemia is also distinct, and the severe risk factors, genetical susceptibility, awareness, cultural beliefs, socioeconomic are all different. So it formulates policies and guidelines that accommodate these differences and proposes to be best suited for our population. So if you see the prevalence, there is typically hypertriglyceridemia and low LDL and high LDL, which is seen in Indian population. So what we did, we had a brainstorming meetings all over the 6 metro cities, and then they gave a recommendation for the Indian population that about who has to be screened, rule out the secondary causes, fasting lipid profile is not mandatory, and identify patient risk category based on conventional and non-conventional risk factors. So that is it. It can be screened before the age of 20 at the time of college admissions, or much earlier whenever we suspect, and non-HDLC should be calculated in every subject. What is a consensus document? They started making a part by part guidelines which suited the Indian population. The part 1 basically deals with common issues related to lipid management encountered during the routine clinical practice. Part 2 gave a specific patient population which came later on. That is, I'll be discussing it later. So what is part one? Part one consciousness is treatment of decision making and treatment easily when has an established ASVD is quite easy to straight away follow the guidelines whichever are there, whichever was there like ACC and ESC. And then, but primary prevention, it varies in Indian population compared to that of the Western population. So we needed to stratify the risk. So which risk has to be used? So this was the risk categories which we usually followed for direct patients who are already had the disease, that is very high risk, moderate risk, with having a 10 years risk stratification, not the lifetime. So what made us think all these coronary artery calcification, carotid intima medial thickness, aortic pulse wave velocity, HSCRP, lipoproteinemia were to be very much associated with the Indian population and was benefited with the statin therapy and were a better control of a dyslipidemia. So what did we think? Lifetime risk calculators, which can be were more better in the Indian population compared to that of the Western population. That is, we had ACC pool cohort, JBS3 and Famiga. But JBS3, that is the Q risk calculator, is found to be comprehensively better for Indian population. It is an app which is available and can just load the data and then we can get the risk. So depending on that, again, we gave an Indian classification as what is that? Very high risk, and low risk as per the other guidelines. And but then calculating the lifetime risk, we considered the moderate and low risk patients who are residual risk for dyslipidemia based on the Indian setup. We have whoever has more than 30, we have reconsidered the further evaluation with non-conventional risk factors and made it moderate and given the lipid therapy as statin therapy as indicated. So what was the goal suggested in the earlier part one of the Indian guideline was very high risk. They made it less than 50 as a target, less than 80 for non-LDL, and for high risk it was less than 70 and non-HDL less than 100. So further they started making a consensus meta-analysis of the data available, and then they basically used all these drugs like a statin, fibrates, dual PPR, bile acid sequestration, etc. in the initial part of the way back. Then when they also considered this non-HDL cholesterol as a co-primary target for treatment. So what happened in part two? They focused on dyslipidemia and comorbidities. So basically, it was the guidelines by the consensus statement of the guidelines which were available. So objective was part two recommended referral patients comorbidities associated with dyslipidemia focused on specific patient population like acute coronary syndrome, chronic kidney disease, alcoholic fatty liver disease, heart failure, thyroid, CVA, and familial hypercholesterolemia came here, and HIV patients. They also considered women and elderly patients who need a better different treatment than that of the Western population. So what happened in heart failure? Usually statins may be administered to the ischemic heart failure having class 2 to 3, but they are not useful for non-ischemic cardiomyopathy or the DCM patients, very useful for the heart transplant patients. What happened in CKD? The established combination of statin and ezetimibe is recommended for the age of 40 years with the EGF for less than 60, and between ages of 18 and 30, CKD should be treated with who are having the following symptoms of high risk and diabetes and known CAD or peripheral artery disease. So in CKD, who are already on dialysis, they don't need to start it new, and who have already received can continue. And what happened in NAF, non-alcoholic fatty liver disease? It continues to be a matter of debate, and treatment of NAF with statin cannot be recommended at present. So what happened in stroke? Stroke patient recommended to achieve LDL target as per AVSD risk, but in all we can give the stroke statin therapy except in acute intracerebral hemorrhage. We don't need to start the statin as a first treatment or the initial treatment, and patients who already received the statin can continue to have the statin therapy. And what happened in inflammatory joint disease is the same as that of the other population. And this is an important topic. Familial hypercholesterolemia, everybody has to be screened from the age of 2 years, who have a strong family history, and recommended to estimate LPA levels. Drug therapy to be started at the age of 8 years. And what is the target? It is again 70 and 100 for children, and 50 and 70 for the adults. And what is inherited hypertriglyceridemia? I will be giving it in a chart in the later part. So in HIV, again, simvastatin, lovastatin are contraindicated, and rosuvastatin can be used as a part of therapeutic treatment. Estimab is another option. Fenofibrate can be used in statin unresponsive HIV. Dyslipidemia in women having collagenous vascular disease, PCOS, preeclampsia, pregnancy, hypertension, gestational diabetes, all are at higher AVSD risk. So there is no difference between the men and female treatment. Only the frail women, older women has to be started with a lower dose. So in elderly, it is the same. No difference between the old age and engaged, but started with a lower dose and go for a higher dose. Post-heart transplant patients are very important to be given the statin treatment because pravastatin shows the least interaction with cyclosporin and the drug of choice. And additionally, statin to cyclosporin sirolimus regime protocol have multiple benefits like reducing cholesterol levels, rejection, and decrease incidence. And what happened in part 3? So part 3 again, the further registries they encountered and found the dyslipidemias in India and the residual risks which were pertaining, and they focused on the atherosclerotic cardiovascular disease per se because the prevalence was increasing compared to that of the Western population, even with the higher dose of statin and optimal medical management. So what was something was deficient there. So they have, apart from the low risk, moderate, high risk, they made a category A and B. So category A was already patients who are having coronary artery disease with greater than one feature of high risk group, and the others which have recurrent ACS and even in spite of LDL being less than 50. So what is the treatment? What did they consider? They considered that change of lifestyle is most important in Indian population. Though the alcohol is considered normal in Western population, the Indian population, even the moderate alcohol is considered to be harmful. So it's not recommended. Carbohydrate 50 to 60%, 10 to 15% protein, and 50 to 30% fat, and fruit and Mediterranean diet was important. What was the goal? LDL goal of less than 50 was indispensable, but less than 30 in category A was optional. So category B, always it is a goal of less than 30. So what is the treatment of based on the other further consensus and further meta-analysis was they made less than 50 as optional. Optional goal is less than 30 and 50 and 80 as treatment goal, and starting the treatment at greater than 50 and greater than 80. So in extreme risk group, it was 30 and 60 and 30 and 50 again. So what is the treatment algorithm? In spite of optimal control, high intensity statin, reinforced lifestyle measurement, even if the LDL is more than 50, add an estimate. Even if it is more than 50 after 3 months duration, consider bempedoic acid, PCSK9 inhibitors, and further treat the dyslipidemia or the residual risk factors which are present in the low and intermediate risk group. So how do you screen? Fasting lipid profile, non-fasting in the first visit, and in patients who have already had fasting, go for the non-fasting so that you see the triglyceride estimation, and here you see the LDL levels and target it accordingly. So one word about diabetic dyslipidemia in India, which is what are the expert conscious statement for the from LIA is, again they consider this category A and B and optimize the LDL and TG controls. So how do they go about? They did the lipid profile at the time of diabetic diagnosis, including APO and lipoprotein A, and they started statin estimate, added fibrates for patients having TG greater than 500. Then they went to PCSK9 in spite of not achieving the goal, and then later on, if they find the triglyceride to be high, they added a fibrate and IPE 4 mg per day, especially if TG is also to greater than 135. So aim is to achieve the HDL, non-HDL, ApoB target at the earliest. So what about hypertriglyceridemia? It is the same. For all these, you see for the LDL targets, non-HDL goal, go for the statin estimate and target levels with omega-43 and fibrates. And patients having 500, 900 and additional pancreatitis risk is higher. So it's a dietary management and lifestyle changes have to be more considered than that of the statin, which are already in the guideline. So in concluding, I say that the recommendation is the statement are not mandatory to the medical committee in India. They are optional of lipidology experts from our country. Clinicians should use their judgment and experience to tailor the therapy for each patient. And AVSD risk assessment, we are using before assessing any Indian patient. LDLC is the primary target for treatment. Non-HDLC is the next target, and equally important in Indian patients. No niacin, no omega-3 fatty acids debatable. Lifestyle modification, integral part of management. Practice primordial prevention. Public awareness is essential to address this epidemic. Thank you very much.
Thank you, Hema, for the comprehensive presentation on Indian lipid guidelines. In the interest of time, I request the panelists to give some brief comments about the two talks and any inputs from their side.
Very nice presentation, Dr. Hema Rath and Rajni ma'am. I have one question regarding this ankle brachial index. What we are given much importance regarding in the ACHA guidelines as compared to the Indian guidelines. In Indian guidelines, you have not mentioned. I mean, the guidelines do not mention about ankle brachial index. Is it?
You ask me?
Yes.
Yeah, actually, patients who are having hypertension or heart failure, this ankle brachial index will give you a further guide to whether they are advancing in aortic stiffness and going into heart failure and other things. So treating this will be an better easy guide for these heart failure patients for the atherosclerotic heart disease to develop, rather than the other guidelines which are there in which Rajni discussed.
Dr. Veenu, any comments, sir?
This is a large topic and they have done a really good job in, presenting the main aspects. Only comment I would like to say is, despite all these guidelines being there and we revising it so much, the prescription pattern when we still see not on statins. So I think it is important for us to learn as well as spread the word forward so that, the patients really benefit from these guidelines. That's about it.
Thank you, Veenu. Dr. Lakshmi?
Yeah, a very good presentation by both the speakers. Yeah, as Veenu was mentioning, it's like most of the time we do risk stratify patients, we do start them on therapy. But, the important thing is also the compliance and also the follow, because we need to reach our LDL goals. So if that is not achieved, then whatever done is wasted. So I think we need to impress upon these patients because this is primary prevention and patient has not suffered any disease, so that, the seriousness of the disease is not there. So we need to impress upon the patients to really come back for a follow-up, have a regular checkup so that we can reach our LDL goals. And another important thing, what I found the difference between our Indian guidelines and the international guidelines, there the LDL targets are more of percentage reduction, more than 50% reduction in each risk category. If it's a high intensity statin, more than 50, or if it's a moderate intensity statin, it's 30 to 50%. But whereas in the Indian guidelines, we noted they are mainly looking at goals. So it becomes easier. Less than 70 for a high risk, or less than 50 for extremely high risk category A, or less than 30 for category B. That way, treatment becomes easier. So I think that way it has been simplified for us.
Thank you, Lakshmi. Any question from the audience? Maybe we can allow one question. It's already 10 minutes late.
They've asked us to make the presentations available, and Madhuri Madam has replied, so it will be available on Wincars.
Okay. Shall we close the session, Dr. Hema?
Yes, ma'am. Thank you so much. Yeah.
Okay. Thank you for all the speakers. They've done a very good job, and the panelists. I thank Dr. Hema again.
Thank you, ma'am. Thank you.
Thank you. Thank you.
So after the first storming section, that was an extremely, power-packed session. So now we will go to our next session and what is new in lipids. Thank you so much. Speakers were excellent, Dr. Hema and Dr. Rajni. Thank you, panelists. All of you. And thank you so much, ma'am. Our next session, session 2, is going to be chaired by Dr. Sri Lakshmi Adhyapak. She is a professor and head of Department of Cardiology at St. John's Institute of Medical Sciences in Bangalore. And Sri Lakshmi, madam.
Good evening.
Over to you, ma'am.
Good evening, Hema. Thank you very much for inviting me to chair this session. I would like to introduce the speakers at the outset. Dr. Shashi Rekha will be speaking on PCSK9 inhibitors. She is a consultant interventional cardiologist at Manipal Hospital, Mysore. And the other interesting topic, bempedoic acid, will be covered by Dr. Pratibha, who works as a consultant interventional cardiologist at Murugod Health Center, Mahalingapur, and is associated with Venkatesh Hospitals. Over to you, Dr. Shashireka.
We have three panelists. Would you like to?
Okay, Dr. Sita, who's a consultant interventional cardiologist at Bharati Raja Hospital, Chennai. Dr. Shilpa, who's an associate professor at Jaideva, and Dr. Cheryl Menzies, who's a consultant at Narayan Hridyalaya. These are the panelists for today's talk. So may I request Dr. Shashireka to start her presentation?
So thank you for the opportunity. Let's a small peek into the history. The Nobel Prize was shared by these two great people, Goldstein and Brown, when cholesterol metabolism regulation was discovered. From that time, we have gone a great deal in the late 90s and the early 20s, where statins have become, the cornerstone or the pillar of all cardiovascular disease management, also in the primary prevention. But from 2017, the great discovery of the PCSK gene and its mutations have led to a wonderful journey for the lipidologists. So the bench to bedside translational research has been made possible by the Nabil Sira group from the Canada. And first, so we'll concentrate on this molecule, the PCSK9, pro-protein convertase subtilisin caxin type 9. Thank God they made it PCSK. I wouldn't be able to pronounce it fully. Now, PCSK9. Now we know that the LDL that is going through the blood vessels is taken up by the hepatocytes by the LDL receptors. Now, these LDL receptors are useful for decreasing the LDL. But the PCSK9, as you can see here, the blue and the pink molecule will inhibit the LDL receptor. And if it is inhibited, the LDL receptor won't be available for clearance of LDL, and LDL will be raised, and that leads to increased atherosclerosis. Now, where is it located, this gene?
Shashireka, your slides are not moving. You are stuck in the second slide. Yeah, now it's okay.
Yeah, ma'am? Okay. So where was this gene? This gene is located in the short arm of the chromosome 1p32. And what does it do? Two things happen. One, when they found that there was a gain of function mutation, that led to increased atherosclerosis. So how did they find out? From the Norwegian subjects with autosomal dominant hypercholesterolemia, there was a gain of function mutation, which led to increased atherosclerosis. So will that mean loss of function mutation will cause decreased atherosclerosis? Yes, it did in a group of African descent people who had low LDL cholesterol and whose cardiovascular events were very, very low. So this led to the concept of why don't we inhibit this PCSK molecule? So that led to three types of PCSK inhibition, either by monoclonal antibodies or the small RNAs or newer things like vaccines. Now, where do they act? So this antibodies will attach themselves to the PCSK molecule and inhibit. Do we have proof for all this? Yes. The first study that came to show that it decreases the cardiovascular outcomes is Fourier study, where about really whooping number of 27,500 odd patients were selected with LDL-C more than 70 or non-HDL cholesterol more than 100, and they were randomized to either placebo or once in 2 weeks dose of evolocumab. And it really reduced the LDL. We got an whooping 59% mean reduction. I mean, this is what the guidelines say, more than 50% reduction in the LDL. And the median decrease in LDL was about 30, which was really good. Now, it compared to the placebo, it outperformed the placebo, obviously, in both the primary outcome of CV death, MI, stroke, revascularization, or hospitalization for unstable angina, or secondary outcome of CV death, MI, or stroke. Now, there was the other molecule which was studied, alirocumab, again, but this was for patients who had definite history of ACS. And again, alirocumab outperformed placebo. which had a LDL reduction of about 37%. Now, these two molecules really set the stage for PCSK inhibition. And the other part, so we got two molecules for monoclonal antibodies. Then came the Orion series. The Orion series actually targeted the formation of the gene itself. It causes slicing of the genes and decreases the production of PCSK itself. And you have Orion 1, that is inclisiran for high cardiovascular risk with elevated LDL. Then you have Orion 2, then Orion 3, and Orion 4 is going on. So from what all these things, what we understand is we have a new molecule that can possibly look at patients who don't achieve. I know these two are busy slides, but the previous speakers have excellently covered all the lipid guidelines. So I'll just go and suggest this algorithmic approach to PCSK inhibitors. Based on the studies that we have so far, when we're not able to achieve the LDL reduction of 50% with maximal tolerated statin, or we cannot increase the statin beyond a point, then even after adding ezetimibe or newer drugs like bempedoic acid, I would say, then we would consider PCSK9 inhibitor. Why does it come in low? The cost of one injection of 140 mg of Tripata, which is being marketed in India, is about 2,000. That amounts to, the cost goes in lakhs. On the right lower side, you see the statins in Jan Aushadhi for 10 mg of atorvastatin is 4.76. But of course, this doesn't really match in Indian population. This is going to be a drug, I don't know when it will reach the population. So let's go on to the third subset of drug that we have. First was antibodies. Second was the RNAs, which slice the PCSK gene. The third is vaccines. Epitope vaccines, especially not the whole gene, just for the epitope, a small peptide that we can form vaccine. Promise is there, but again, it costs a lot. It costs about 65 to 75,000 per vaccine, according to the US market. Now, but then India, after the COVID, we know we are the vaccine capital of the world. Can we make vaccines for our population, which is so prone to atherosclerosis? Make in India, let's keep our hopes up. But the other thing also, which is coming into picture, is naturally occurring PCSK9 inhibitors. And they are found in the commonly taken.
Yes, can you please conclude a little faster?
Last slide, ma'am.
Okay.
So the naturally occurring PCSK9 inhibitors are maybe a hope, because they are found in common medicines, like common food substance that we take, like turmeric. So with that, I conclude, and thanks for the wonderful opportunity. Thank you.
Thank you very much, Dr. Shashireka, for that nice talk. Over to Dr. Pratibha, who's talking on bempedoic acid.
Yes.
Dr. Pratibha?
Yes, ma'am. Good evening, eminent professors and my dear colleagues. I'm Dr. Pratibha, and today I'm talking about bempedoic acid, a non-statin lipid-lowering drug. As an introduction, it's already been discussed. We know cardiovascular disease is the leading cause of mortality worldwide. 1 out of 3 deaths occur due to cardiovascular disease, and more so in India, as discussed by Dr. Hema, involving younger population. Ischemic heart disease and stroke are predominant causes of deaths in India. Obviously, the treatment option, dyslipidemic drugs play an important role. Statins being the most important. We have fibrates, intestinal cholesterol absorption inhibitors, and PCSK9 inhibitors. Most commonly used statins is atorvastatin and rosuvastatin, and we know it inhibits HMG-CoA reductase, thereby decreasing the cholesterol synthesis, increase LDL receptor upregulation, and thereby increase the resorption and hence decrease the serum LDL levels. And we know the outcome. It reduces the endothelial function. Endothelial function is reduced, inflammation will be reduced, endothelial function is restored, ischemic episodes are reduced, vulnerable plaques are stabilized, cardiac events are reduced.
And maximal LDL reduction was seen with high doses of rosuvastatin as compared to atorvastatin. And various studies have shown the benefits of statins in both primary and secondary prevention. The thing is, we know that there is a reduction in relative risk by atorvastatin or rosuvastatin, but with that, there is a significant residual risk associated with the even with optimal dose of statins. So, can we increase the dose of statin? The most, if all the guidelines recommend high doses of statin if there is no optimal LDL reduction. But the problem is with a high dose of, even when they used a high dose of atorvastatin, still there was a significant residual risk for cardiovascular morbidity. And SAMs being the most common symptoms associated with statins, which makes the patients, which affects the adherence to the drug. And because of this, there will be significant discontinuation. And also, statins are associated with higher odds of diabetes and transaminase elevation. As previously discussed, high-intensity statin therapy is recommended. It's the class 1A recommendation. Suboptimal LDL response is seen to statins. The main barriers being physician-related, it can be patient-related. Physician-related, when they prescribe low-potent statins, when there is unawareness of guidelines, there's fear of adverse reaction or drug interaction, reluctant to up-titrate drugs when goals are not achieved. Patient-related factors where because of the genetic background, when it is homozygous familial hypercholesterolemia or lack of adherence or persistent to the treatment. Suboptimal LDL response leads to increased severe CVD risk. Most of the guidelines, international guidelines, have suggested maximum dose of use of maximum dose of statin followed by estimate. And if there is still LDL is more than 50%, then one can add PCSK9 inhibitor. But the problem with these drugs is we know maximum tolerated dose of statin is associated with SAM, which leads to discontinuation and therapy failure. Estimate is supposed to be associated with abdominal pain and diarrhea. As Dr. Shashireka discussed, PCSK9 is amazing, but it is an injectable drug and high cost of therapy. So here comes bempedoic acid, which is a new lipid-lowering armamentarium. This is a prodrug which is converted to active component of bempedyl-CoA by enzyme very long chain acyl-CoA synthase 1, which is mostly expressed in the liver. This competitively inhibits cytosolic enzyme called ATP citrate lyase required for conversion of citrate to acyl-CoA. So once this is inhibited, there is decreased acetyl-CoA, thereby there is decreased fatty acid synthesis, increased fatty acid oxidation, and decreased cholesterol synthesis, which lead to increased LDL receptor upregulation and decreased cholesterol synthesis, and thereby decreasing the LDL-C. And also because of AMPK activation, there is fewer diabetes, there's reduced risk of diabetes, the new onset diabetes with bempedoic. And bempedoic also inhibits organic anion transporter proteins that leads to increased uric acid and creatinine, which leads to adverse effect caused by bempedoic acid. And since acyl-CoA synthase is present mainly in hepatocyte and absent in skeletal muscle, there is minimal muscle symptoms with bempedoic acid. Indication, as per the guidelines, that it is used in primary hypercholesterolemia, heterozygous familial and non-familial, or mixed dyslipidemia. And in combination with the statin or statin with other lipid lowering therapies, where patients are unable to reach LDL-C goal. Major, plus point is that it's a protective mechanism against myotoxicity because, as I told, acyl-CoA very long chain acyl-CoA synthase is present only in the liver and not in the skeletal muscle, reducing the myotoxicity. And clinical trials supporting the bempedoic acid, mainly the CLEAR trials involving 17,000 patients. There are 5 trials: CLEAR Harmony trial, CLEAR Wisdom trial, CLEAR Serenity trial, CLEAR Tranquility trial, and CLEAR Outcomes trial. The first evidence is the CLEAR Harmony trial, wherein the objective was to assess the safety and side effect profile of the bempedoic acid when it was added to the use of maximally tolerated statins for 1 year. Primary endpoint was incidence of adverse events and changes in safety lab variables. There was fewer side effects compared to the placebo, and definitely there was 80% LDL reduction at week 12, and which was maintained at week 24. In conclusion, in this 52-week trial, bempedoic acid added to maximally tolerated statin therapy did not lead to a higher incidence of overall adverse events than placebo and led to significantly lower LDL cholesterol levels. Every doubling of statin dose causes an average of only a 6% reduction in LDL cholesterol concentration, which is known as rule of 6. But with bempedoic acid, when they added bempedoic acid, there was greater than 6% reduction in LDL. Coming to the second evidence with clear wisdom trial, here the objective was to see the efficacy of bempedoic acid versus a placebo in a patient at high cardiovascular risk receiving maximally tolerated lipid-lowering therapy. Again, the primary endpoint was the percentage change in the LDL-C from baseline and at week 12. So at week 12, there was a significant reduction, that is 17% LDL reduction at week 12. And this was maintained through week 52 in bempedoic arm. And definitely other lipid parameters, there was significant reduction in non-HDL-C, total cholesterol, apolipoprotein B,
Can you
HSCRP.
please go a little faster, Dr. Pratibha?
Yes, sure.
Yeah.
Sure. In clear serenity trial, the efficacy, safety, and tolerability of bempedoic acid versus placebo in statin intolerant patients requiring lipid lowering therapy for primary or secondary prevention was studied. Again, here there was significant reduction in LDL-C by 23.6%, which was observed at week 12. And clear the next trial, it was bempedoic acid was the efficacy and safety was studied when it was added to the background therapy with estimate 10 mg daily in patients with history of not tolerating at least one statin and who required additional LDL-C lowering. Even here, there was significant reduction in LDL-C with bempedoic arm and were maintained throughout the 12-week study. In clear outcome, bempedoic, it was well tolerated in mixed population of primary and secondary prevention patients unable or willing to take statins. LDL-C was lowered by 21.7%, and primary endpoint 4-component MACE was reduced by 13%. And in 13 randomized control studies where the safety and efficacy of bempedoic acid alone or combining with other lipid-lowering therapies were meta-analysis was done, which showed that both bempedoic acid monotherapy and combining with statin or estimate were all significantly reduced LDL-C levels. Common adverse effects being anemia, gout, and hyperuricemia, increased aspartate aminotransferase, pain in extremities. There was increased serum creat, blood urea, and decreased GFR, which was less common. This is from the clear outcome, which showed elevated hepatic enzyme, renal impairment in 11.5%, hyperuricemia.
Pratibha, can you wind up, please?
Sure. It is contraindicated in severe renal and hepatic dysfunction and patient with history of tendon rupture or already with a history of gout. And as discussed by Hema, in Lipid Association of India also considers bempedoic acid after the addition of estimate 10 mg for the LDL-C target. In patients with true statin intolerance or contraindication, estimate 10 mg once a day in combination with bempedoic acid is recommended. It can also be used in diabetics because metabolic syndrome, because there is decreased rate of new onset diabetes, and due to its minimal side effects and drug interaction, it can also be used in HIV patients. In summary, it is a novel mechanism. The main thing is reduced myotoxicity and reduced new onset diabetes. It is better tolerated. It is addition demonstrated 28% reduction in LDL-C with once daily dose. So it is a promising drug for patients requiring additional lipid lowering therapy. And it is a promising drug in patients who are statin intolerant, and it fills the same gap as estimate when PCSK9 inhibitors. Thank you.
Thank you very much. Any questions from the panelists? Any questions? Okay, I have a question for you, Dr. Pratibha. Where does bempedoic acid fill the gap when it comes to Indians? As you know, Indians are a special population with dyslipidemia. So where does that fill in the gap? Do you think it fills the gap?
In Indians, because we need the target of LDL is less than 50 mg per deciliter. I think when we use high dose of statins, patient tends to, stop the dose because of the side effects. I think it helps there along with estimate. And also because metabolic syndrome is more in Indian population,
yes,
it's an additional benefit.
Yeah. Any other questions? Anybody wants to say anything?
Ma'am, when should we start bempedoic acid after addition of ezetimibe?
At least 3 months now. It's 3 months of estimate.
Okay, and any cutoff level of GFR or increase in creatinine, we should stop bempedoic acid. Is there any cutoff, because it gives that with time the GFR may improve or creatinine may come to normal
So you
after
can
starting?
use it up to grade 2 to 3 renal dysfunction, not beyond.
Okay.
What do you think about combination of statin and bempedoic which are there in the market as drugs? What is your say in that?
Bempedoic and estimate, ma'am.
No, bempedoic acid and any statin, they are giving a combination of those rosuvastatin, atorvastatin with that of bempedoic acid.
Yeah. So it can be given, ma'am, but the thing is, once they start, bempedoic enhances the side effect of statins. So that should be kept in mind, actually. If patient is on higher dose of statin in that combination, it can enhance the side effect of statin.
You recommend combination, or I don't think so?
No.
Okay, with that, I hand over the session to Dr. Hema.
Thank you so much, ma'am. Thank you.
Thank you very much.
And thank you, Professor Shulakshmi. It was amazing to have you with us. And thank you both the speakers, Dr. Shashilekha and Dr. Pratibha. And thank you all the panelists. Maybe at the end of the session, if there is more time, we can go for some more discussion. But now we have another exciting session coming up. It is lipids in special populations. I call upon Professor Vijayalakshmi to chair this session. Professor Vijayalakshmi needs no introduction. She is an eminent and very famous professor of pediatric cardiology, and she was head of department in Jaydeva, Bangalore. She's an excellent speaker. She is culturally very active. She's a dancer and a classical singer. And ma'am, with these few words, and you are you're all most of our teacher that we have been having the fortune to be with. Ma'am, I hand over the session to you. Thank you.
Thank you very much, Hema. And that's a beautiful Himalayan picture by Nagamani. And we are going to the third session, which is going to have two speakers. One is Nagamani. Nagamani does not require any introduction, but however, she's a professor head of the unit in Sri Jaydeva Institute. I know her from the day she joined for her DM cardiology. She's a very dedicated, very hardworking, very sincere person, and she has a great oratory skill, and she is a brilliant speaker. And the second speaker is Dr. M.K. Usha. And Usha, I know her again from the time she joined Jaydeva as a postgraduate. And she is a very kind and a very sincere, hardworking person, very dedicated to her work. And she did her undergraduation in Bangalore Medical College and post-graduation in St. John's, and then postdoctorate, that is the fellowship in Jaideva. And in the last 15 years, she has evolved herself into a brilliant interventional cardiologist. And her study on thiamine and the pulmonary hypertension in infants had a great review. And here I present Nagmani for you first, and then we move on to Usha. Nagmani. Women in the lipid scenario, and that is the tailor-made for you.
And we have 3 panelists. Just an introduction, yes.
The 3 panelists, first is Sunita. Sunita Maheshwari needs no introduction. She is a good friend of mine and a most lively person I have ever met. And she was working in Narayana, and now she is on her own, doing a great job in the telemedicine. And the second one is Dr. Chaitra, Assistant Professor of Cardiology, again from Jaideva Institute of Cardiology. And the third panelist is Dr. Maria Jyoti, Consultant Interventional Cardiologist from Apollo Hospital, Bannerghatta. So we'll have the 2 speakers and then comments by all the 3 panelists, and then we'll take up the questions. Thank you.
Good evening, everybody. Thanks, Vijayalakshmi Madam, for their kind introduction. Let me start off. I will be discussing the present topic under these headings. Is there a difference in ASCVD between men and women? What is the traditional view of ASCVD? What do the guidelines say? And what are the changes in the life of a woman and its impact on lipids? I'll have a brief note on dyslipidemia in special circumstances like pregnancy, menopause, and what's the role of hormone supplementation post-menopausal period, and what are the biases which exist, and what does the future hold good for us. If we look at the atherosclerosis and vascular disease risk factors, the risk factors are the same for both men and women. Dyslipidemia is an important risk factor, but it is highly prevalent in the women. It is demonstrated in around 30% of population in the US. And according to ICMR guidelines in India, 78% of the population, I'm including both men and women, they have at least one lipid abnormality, the commonest being low HDL and the second commonest being high triglycerides. Probably that could be because of our increased carbohydrate intake, and high LDL cholesterol is the third commonest. And we know from various primary prevention and secondary prevention trials that there is an association between the LDL cholesterol reduction and reduction in the CV incidence. And this is common to both men and women. So what is different? How women and men are different? Women present later with cardiovascular disease. As we know, it is at least a decade later. And the main cause of mortality in women is cardiovascular death, accounting for at least 50% of mortality in women. In spite of this, women receive less aggressive therapies. Why is this so? Because the trials which have studied many of the cardiovascular risk profile and the medications, they have underrepresented women. But I think the trends are changing. If we look at the trends in representation of women in lipid-lowering trials, in 1990s, women constituted around 20%, but there is consistent improvement in this, amounting to around 30 to 35% representation in the trials now. The main trial of PCSK inhibitor, it has overrepresented men, around 75%, and the alirocumab trial has underrepresented, around 25% women were represented in the trial. The latest trial with bempedoic acid, that is Clear Outcomes trial, we see a good representation of women. But I wonder whether this is because the bempedoic acid was used in statin intolerant patients. And we know that women tolerate statins badly. So probably that was the reason women are more represented in this trial. Is there a difference between the medications and the practices? When we extrapolate from men, there is a apprehension that it can cause serious side effects in women. So we need more sex-specific data for optimal risk management. But we do know that from various trials, men and women behave similarly with respect to prevention. If you look at the vascular event reduction with reduction in LDL cholesterol, with the CTT, this is cholesterol treatment trial is group, they have demonstrated that event rates were similar in women and men with statins. So what do the European Society guidelines say with respect to management of dyslipidemia? Statin treatment is recommended for primary prevention of ASCVD in high-risk women, because this was a controversial topic few years back. There was a doubt regarding the role of statins in primary prevention as compared to men, but now that confusion is cleared and it is definitely recommended for primary prevention. And statins are recommended for secondary prevention with the same indications and goals as in men. But lipid-lowering drugs are not recommended when pregnancy is planned or during pregnancy or during lactation. If we look at the lipid metabolism through a woman's life, generally at birth, total cholesterol is around 65. It increases to 165 at the end of 2 years, and it remains stable during the childhood period. And then after 20s, we know that HDL is at least 10 mg% more in women as compared to men. So what happens when there is early menarche or longer reproductive period or early menopause? This is associated with increased body fatness and dyslipidemia, and elevated childhood BMI predisposes to earlier menarche, and childhood obesity is one of the causes for dyslipidemia, and this can get converted to cardiovascular events later in life. This has been well studied in a Chinese study. Around 9,000 women were studied, and they have demonstrated that cardiovascular events are more if there is early menarche or long reproductive years or early menopause happens. And we know that in women's life, teenage to pregnancy is fraught with hormonal shifts. And OCPs are used for either menstrual cycle irregularities or as contraception. Estrogen in the OCP can increase triglycerides and high density cholesterol, and it can marginally reduce LDL. And another reproductive age group women, the problem we commonly see is what is called as PCOD. They have insulin resistance, they can have dyslipidemias, and mainly lifestyle changes will help control the dyslipidemia in them. What happens in pregnancy? Pregnancy leads to increase in LDL, triglyceride, and cholesterol levels. It peaks around 36 weeks. This is probably because of the hormonal effect. So pregnancy can occur with de novo dyslipidemia. This we are seeing now with late pregnancies. They can have familial hypercholesterolemia or metabolic syndromes. Dyslipidemia in pregnancy is noted to have worse fetal outcomes. Large for gestational age babies, preterm, preeclampsia, and congenital malformations are also known. But does gestational dyslipidemia lead to later onset issues? There is no data on this. And best time to screen is the pre-pregnancy period or just after confirmation. We don't do this generally for pregnant women, but it is required. And in patients with de novo increased triglycerides, the triglycerides can reach up to more than 500 mg% during third trimester. There can be risk of pancreatitis, and there can be confusion in the diagnosis as well. So how do we manage dyslipidemia in pregnancy? Statins are important, but they are contraindicated in pregnancy because the earlier trials showed that there can be teratogenic effect of the statins. But FDA has now removed the warning, and there are no known teratogenic effects with hydrophilic statins like rosuvastatin and pravastatin. And bile acid sequestrants can be used safely. Then during lactation, again, we don't have clear data. There is no evidence of harm, but FDA doesn't recommend it. And if at all we have to use hydrophilic statins. And bile acid sequestrants are safe again. Premenopausal women have low proatherogenic lipid milieu as compared to men of the same age. This we are aware. But with the aging, there is change in paradigm and LDL starts increasing. While 10-year ASCVD risk may be low for a woman, as they live longer, lifetime risk may be elevated. And a word on HRT, that is hormone replacement therapy and dyslipidemia. The OCPs, we know it can increase the risk of venous thromboembolism. But what about the risk of ASCVD? This is less well established. And what's the role of postmenopausal hormone replacement therapy? We expect an increase of HDL and decrease of LDL by 10 mg% with HRT, but this beneficial lipid changes does not translate to reduction in cardiovascular disease. And Women's Health Initiative trial showed increased CVS with HRT. And as already alluded to, women have special risk enhancers in the form of premature menopause and pregnancy-related factors, and even inflammatory risk factors are more common in women. Triglycerides and lipoprotein A levels are high in women. And what about the diagnostic modality? If we calculate the risk in women, even though if they have a Framingham risk score low, but coronary calcium scoring shows that risk may be elevated. So coronary calcium score has increased benefit in women more than men in identifying risk of ASCVD. Menopause heralds the decline of estrogen and ascent of atherogenic lipid milieu in the blood. And the older women have disproportionately more CVD risk than men when the calcium score is more than 0. And when it comes to management of dyslipidemia, it is no different in men and women. We have to concentrate on aggressive lifestyle modification, and dietary modifications are the same for both. But if you look at the relative risk reduction in statin trials in women in both primary and secondary prevention, it is quite good, except for the Forest trial. It is both the same for men and women. If we look at the equivalence of lipid reducing agents, both of them equally benefit from statins, but women are underprescribed, underdosed. Guideline-directed medical therapy penetrance is less in women, and they are less likely to achieve target goals. And they are more likely to discontinue statin therapy due to statin-associated muscle symptoms. And they are less likely to be satisfied with the doctor and their advice. So our concentration should be on, spending more time on explaining the importance of statins and importance of the follow-up, and that is very, very important. So what do I conclude? More inclusion of women are needed for current trials, and this may lead to specific guideline recommendations for women. But essentially, what works in men works equally well in women. But specific differences do arise during obvious times, that is childbirth and lactation. And caring for a woman needs to be less paternalistic. So doctors should not decide what is right for the women, and we should allow women to decide, and it should be a shared decision making. It should be free of biases, and it should be more inclusive. Thank you.
Dr. Nagbani, that was brilliant presentation. In fact, I remembered my younger hood when I first time ever made a speech as a cardiologist. The topic given to me was about the lipids. And then I told Dr. Professor Chandrasekhar Rao, sir, it is a very boring topic, sir. Please let me speak on interventions, because it was in the mindset that only interventions can be excellent, but medical interventions are not as interesting as that. And then he told me one thing, Nodamma, no topic is interesting or boring. It is you who make it interesting or boring. So today I enjoyed your talk and it was so lucid, so clear. And I remember one more incident. I started the campaign, Change the Gender Bias, because the women with the chest pain were not treated for cardiovascular disease at all. So the same thing applies here. And the second important point that you made is the obesity, the childhood obesity and also obesity in women. Now, post-corona, it has increased by 30%, and cardio-diabetic thing, is going to be like a wildfire. So we have to be very careful, target and primary prevention. As you said, reduction in weight and exercise are very important. But one thing we have to remember that just because a woman is not fat, that doesn't mean that her cholesterol may be normal. So we have to be careful either way. So I think you have to start like how I started Change the Gender Bias. Now you have to start that again and see that the more and more women are brought in the net of cholesterol control. I think we'll move on to the next lecture and then you please stay with us. We'll take up the questions and the comments from the panel. Now I invite Usha.
Thank you, ma'am. Good evening, everyone. I thank the Wincars Association, Dr. Hema, for this opportunity to present on pediatric lipid disorders. The saying goes, adulthood does not exist. Man is an eternal child. Well, this applies for most of the pediatricians. They continue to remain in that age group of pediatrics along with their patient. But this seems to apply for today's topic, which is pediatric lipid disorders too. How is it so? So today I have structured my talk on these headings. What are the disorders associated with pediatric dyslipidemias? How to risk stratify them? How to screen and evaluate them? When to intervene? And what are the goals of treatment? And what are the different aspects of management? So why should you discuss about pediatric lipid disorders? It is a disease of adulthood. Please remember that atherosclerosis begins in childhood and tracks into adulthood. Childhood provides opportunity at preventing, modifying, eliminating these risk factors. And in doing so, we can reverse or slow the process of atherosclerosis. And the severity of atherosclerosis is directly attributable to the lifetime exposure to elevated LDL cholesterol. And there is gold standard evidence that firmly establishes the causal and likely life course benefits of reducing LDL-C, increasing HDL, and reducing triglycerides. So we know that in adults with untreated familial hypercholesterolemia, coronary artery disease occurs quite early in life. So what is different with Indian children? This is one study published in JAC, a very beautiful study where 2,500 children between ages of 14 to 18 years from suburban Delhi were included in the study. And they were from all socioeconomic strata. There was a high prevalence of atherogenic lipid profile in the form of elevated triglycerides, low HDL levels, and high BMI. 10% had had LDL more than 110, 18% had triglycerides more than 130, and HDL less than 45 was seen in as high as 48%. So the track of atherogenic dyslipidemia starts in childhood and is what is seen in adulthood, as we have heard in most of the previous talks. So what are the types of lipid disorders in children? So they can be divided into genetic disorders, where there is increased LDL-C. The common examples of we all know is familial hypercholesterolemia, combined hyperlipidemia, and chylomicronemia. The next type is the lifestyle-related lipid disorders, where you have moderately elevated triglycerides, lower HDL cholesterol, and increased small dense LDL, which is commonly associated with either obesity or overweight, where the risk of ASCVD increases 2-fold to 3-fold. But don't, like Vijayalakshmi madam already told, a lean child also doesn't mean is free of a lipid disorder. 10% of normal weight individuals have lipid abnormalities. Looking at it the other way, 35 to 45% of youth with lipid abnormalities are normal weight. So which are the other disorders where you have to keep dyslipidemia in mind? The most common, the Kawasaki disease, where it's not the dyslipidemia, but it's a stringent management of lipid profile, which is important for preventing cardiovascular diseases. Children on dialysis, CKD, liver disease, PCOD, which Dr. Nagmani already mentioned, growth hormone deficiency, inflammatory disorders like SLE, juvenile idiopathic arthritis, psoriasis, they are all prone for dyslipidemias. Post-cardiac transplant and post-stem cell transplant are also children who require evaluation and monitoring for dyslipidemia. So ultimately, the unifying mechanism for all this is inflammation, and we all know and have discussed in detail in previous talks. So this inflammation leads to insulin resistance, which maintains the glucose at a very high level for the metabolic demands and leads to ultimately atheroma formation. So the most common in children, which we are all dread always treating because it is so resistant to treatment and associated with life-threatening cardiovascular complications. This is the familial hypercholesterolemia, which is autosomal dominant, and the homozygous variety, which presents in children. Like you see, this is one of our patient who was 8-year-old who came with class 3 symptoms, and he had this xanthomas, and he had supravalvular aortic stenosis and hypertension with LV dysfunction. These occur due to various mutations in LDL receptors, sometimes in ApoB100 or PCSK9. And the incidence is around 1 in a million, and LDL is always above 500 milligrams per DL in these children. And you have coronary events before second decade of life. Familial combined hyperlipidemia is another most common inherited dyslipidemia, where you have a combined elevation of VLDL and LDL. And the other disorder where the triglyceride is elevated more than 1000 is familial chylomicronemia syndrome, and these children are at risk of pancreatitis. But the most common what is seen in adulthood, which starts a subclinical manifestation in childhood, is the heterozygous familial hypercholesterolemia, which occurs in 1 in 250. So these patients require screening at 2 years, especially if there is a family history of premature CVD. And 20-year follow-up when treated with statin shows that there is no difference in carotid intimal medial thickness when treated early in childhood, and they compare with normal population. So how do you detect these children? There are various types of screening. Clinical screening, which is impractical. You can't check on children for xanthelasmas and xanthomas. Family history screening, where you check the affected family members, but 30 to 60% get missed. There's something called cascade screening, where you detect each patient and screen all the family members, pick up patients and screen their first and second degree relatives. But what is recommended is universal screening. Genetic screening is also not feasible because there are too many mutations. So universal screening is based on the normal lipid pattern levels in children, which slightly dips down during adolescent period. So you do a screening just before adolescence and just after adolescent. So from birth to 2 years, usually the lipid levels are stable and no screening is required. Selective screening should be done between 2 to 8 years of life if there is a family member with premature ASCVD, and with one of the following risk factors like diabetes, cigarette smoke, Kawasaki disease, CKD, and various Kawasaki disease. Universal screening is what is recommended by NHLBI in 2011 guidelines, that you look for lipid levels between 9 to 11 years once, and then once at 17 to 20 years. Usually, at the first visit, you can look for a non-fasting, non-HDL, and fasting should be done if it is more than 200 milligrams. And you repeat twice within 3 months and take the average readings. There are various cutoffs as to what is acceptable, what is borderline, and what is high. So total cholesterol more than 200 is high, with LDL cholesterol more than 130. And similar to risk stratification in adults, we have high risk, moderate risk, and low risk in children. Just would like to highlight a few things in high risk: diabetes mellitus, homozygous familial hypercholesterolemia, Kawasaki aneurysms, and post-transplant. Heterozygous comes to moderate risk, and childhood cancer survivor and pre-dialysis CKD also comes to moderate risk. Inflammatory syndromes, PCOD, regressed aneurysm comes to low risk category. So once you decide to evaluate them, what all things do you want to do? Do a fasting lipid profile, smoking history, look for a family history of early CAD, fasting glucose with HbA1c, and physical activity history, blood pressure, BMI, LFT and CK before initiation of therapy, and renal functions and thyroid function tests. So when to start therapy, the cutoffs are almost similar. Even the treatment pattern is similar. LDL-C more than 130 in high risk category and more than 160 in moderate to high risk category. And what should be your target? In high risk, you aim for a reduction of LDL up to 100 milligrams per DL and HbA1c less than 5.7, with BP less than 90th centile. And moderate risk, the target is slightly at little higher at 130 milligrams per DL, and the rest are same. So how do you start intervening? Most important is a lifestyle and a diet modification, having family meals with healthy diet, avoiding snacks, avoiding saturated fats, avoiding sugar sweetened beverages, avoiding eating food while sitting in front of TV, including avoiding having a TV in a bedroom, go a long way in providing diet and lifestyle modification, which can reduce cholesterol by, which can reduce the LDL-C by 10 to 20%. And this is the Mediterranean diet, which all of us know, where fruits and vegetables around 4 to 5 cups per day, fish twice a week, nuts of soya, walnut, mustard, and flaxseed oil, avoid red meat and whole milk products, zero sugar sweetened beverages, and all carbohydrates should be in the form of whole grains. And for children, what is advised is at least 5 hours of vigorous physical activity. So that comes to actually around 1 hour of playtime every day and less than 2 hours of non-school related screen time. So this shows that this kind of diet improves the carotid intima media thickness test, which is an early marker of atherosclerosis. And even good sleep is also very important for managing dyslipidemia children and avoiding having a smoke-free environment. So there are various types of diet with very stringent control of fat, but the focus is on not on losing weight, allowing for adequate growth, but reducing the amount of trans fat and limiting the dietary cholesterol. So a more stringent diet is the child 2 diet, but the focus again here is on simple carbohydrates instead of complex carbohydrates. So we should replace simple carbohydrates with whole grains, whether it is unpolished rice being replaced with brown rice or eating whole grain breads, and increasing the omega-3 fatty acid intake. Statins, like adult management, are the cornerstone of therapy. We know that it not only reduces cholesterol synthesis, but also regulates inflammatory response, has a role in apoptosis and immunomodulatory effect. What was important was there was a lot of concern regarding the side effects, but most of the studies have shown that these side effects are minimal and tolerable in children. When do you start statin therapy? If high-risk population, LDL-C more than 130, along with in parallel with lifestyle change, whereas in moderate and low risk, you can give a trial of lifestyle and diet change for 3 months, and you start if the LDL-C does not reach the desired levels, and the cutoff is around 160 milligrams per DL. So there are various statins approved as early as 8 years of age, and the largest Cochrane database shows that statins are safe and effective. Pravastatin and rosuvastatin are the ones which are FDA approved for very young children at 8 years of age with a maximum dose of 40 and 20 mg. Other statins are approved from 10 years of age. So elevated triglycerides, phenofibrate and omega-3 fatty acids are required when there is very high triglycerides, especially to prevent
dear Usha, sorry for interrupting you. Can you summarize? Because we are supposed to finish at 9 o'clock. We are already 9.
I will show one last slide on management of homozygous familial hypercholesterolemia. So this is what is the challenge in pediatric dyslipidemia management. So as we discussed, statins and estimate are the first line. Since the cholesterol levels are very high, plasmapheresis is required. PCSK9 is currently approved and has undergone successful phase 3 trials and is shown to provide a significant 40% reduction. And the 2 new agents, which are MTP inhibition and ANGPTL3 inhibitions, also have undergone trials, though they had small number of children with 3 to 6 subjects. They have also been FDA approved for treatment in homozygous familial hypercholesterolemia. Start screening for hypertension from 3 years and screen for hypertension at every clinical visit. One last slide, that statins have been shown to be of benefit even in an inflammatory stage of Kawasaki disease and not just on the follow-up stage due to its anti-inflammatory effects. And there seems to be a role of statin in acute Kawasaki disease. So in conclusion, it is important to have universal screening programs for evaluation of risk factors, avoid westernization of diet rich in simple carbohydrates and sugars, focus on outdoor playtimes and reduce screen times. It's very important to have epidemiological research on prevalence of modifiable risk factors. And the most effective way for treatment of any disease is primordial prevention. Thank you.
Thank you very much, Usha. That was a brilliant presentation. In fact, rightly you put saying that the important point that the lifestyle change is very, very important in the present generation with the sedentary habit and addicted to the mobiles. And now the youngest child I had was a triple vessel disease at the age of 9 months, the familial hypercholesteremia. And I was shocked to see that the cholesterol was 1,500 milligrams total. An unimaginable triple vessel disease at the age of 9. He underwent bypass surgery. But one thing is the statins don't help in the familial. And there, the liver transplantation is the only way to salvage the problem in the children. And now I call upon the moderator, the first panelist, Dr. Sunita Maheshwari, to make a comment or any question. Sunita, I would like to see you beautiful. Wow. Let me give you a hug and
hello.
Okay. Yeah.
I think lovely presentation by Dr. Usha. I just had a question, maybe, to clarify for the audience. Usha, you mentioned the screening protocol and you said obesity was in low risk. Today in India, we're seeing a lot of kids who are very overweight. So what should our recommendation be to pediatricians today? When you see someone who's obese, should they automatically get, the lipids, or should we just say, okay, work on lifestyle and come back? You showed some guidelines, but I don't know in India today, what would you say should be, what is being done currently and what is ideal that we should be doing?
Ma'am, actually in the screening guidelines, the screening ages, what is mentioned is for the general population. If you have a risk factor, any of the modifiable risk factor, you're supposed to start screening early, which can be as early as 2 years of age. And if the BMI is high, then you should immediately screen them for all the metabolic syndrome factors. And of course, genetic obesity is also a part of it. And lifestyle modification, it comes under the risk category of ACC guidelines. It comes under moderate risk category. And the actual cutoffs for lipids is LDL of up to 160, beyond which you are supposed to start medical management. But you're supposed to give a trial of 3 months of lifestyle changes and dietary changes. And if we are not reaching our targets, then statin therapy is recommended in obese children. Only the numbers of ACVD is lesser, but it does not say that intervention should not be offered in these children.
No, so that was the guideline now in India is that every obese child should have is having lipid screening.
Yeah, it should be done, ma'am. It should be done. That's what the endocrinologist, most of the time we refer to endocrinologists, and that's what they are doing.
See, because most of these kids will be seen by pediatricians, the overweight, obese kids. They won't necessarily get to endocrine. So would our pediatricians sending, I mean, we don't get so many referrals unless a kid has a xanthoma. So
very true.
That
actually, obesity is not considered a disease in our population.
Yeah.
And obese children are supposed to be well-grown children. And there is a significant lack of awareness about looking for dyslipidemias in the medical population itself. And I think having such CMEs will definitely increase the awareness among doctor population.
Yeah, I think that's then something that we need to take from cardiology forums into pediatrician forums.
Yes, and one more thing, Sunita, apart from the screening the obese children, usually I say in the radio talks, the children may inherit the property or not from their parents, but they inherit dyslipidemia and diabetes and hypertension. So if the parent, they had early premature coronary disease and they have dyslipidemia, and those children should be all started screening right from the beginning. Now we move on to Dr. Chaitra. Please make your comment or your question, please. Chaitra.
Yeah, good evening, ma'am, and good evening, everyone. Yeah, my question is based on especially in a pediatric population, those nowadays we are seeing the premature CAD in a higher rate. So
Correct.
most of the kids will be at a high risk of having a future atherosclerosis or coronary artery disease.
Absolutely.
So anyhow, madam has explained very well that we have to start screening early. So if we screen early and we find any dyslipidemia, apart from this familiar or congenital, only if there is any elevation or variations in LDL and HDL, we start them on a statin. And once they reach the target level, whether we need to stop them on stop the medication and then screen, is there anything we need to continue at least low dose statin after the age of adolescence or anything, if not in 2 to 8 years of age or anything?
Hi, Chaitra. Yeah,
Hi,
thanks for that
yeah.
question. Right. Yeah, see, most of so far, whatever children we have had who have been requiring statins are under the group of hypercholesterolemia syndromes. So we have not had an opportunity where actually we have even reached the target LDL levels. And in these genetic syndromes, LDL levels actually remain very high, and even starting second line of treatment due to various drawbacks, whether financial or logistics itself has been difficult. And with regard to your question, what the literature says is, once you have reached your LDL target levels, you can reduce the dose, make it alternate day or even twice weekly doses if you are maintaining your LDL levels at your target level. So you can try reducing the dose and see, but it's important that diet and lifestyle modifications are maintained in parallel with medications.
Thank you, Chaitra and
Thank you,
Usha.
ma'am.
Now I request Dr. Maria
Thank you.
Jyoti to make a comment or question, please. Dr. Maria?
Hi, ma'am. Good evening. Sorry, I'm seeing the other way around, I think. Yeah.
Oh my God.
Probably it is other way around. Okay, ma'am, it's okay. So, ma'am, thank you for it was a wonderful session. My question is basically for Nagamani, ma'am. Usually in what we see is the females tolerate the statins lesser compared to the males. So, of course, we even try them with the bempedoic acid at a later date. So we can't give them the highest dose. We've seen many people coming with the muscle weakness or tiredness and they feel very fatigued. So what about your thoughts about this, ma'am?
Yes, actually, the statin-associated muscle symptoms are more reported by women. But there have been studies, where they say that what we call as statin-associated muscle symptoms are basically, it is called a nocebo effect. There is a question raised that whether statin-associated muscle symptoms exist. Basically, we have to look into other factors which can contribute to these symptoms, like they may be having associated vitamin D deficiency, hypothyroidism, or certain reversible factors. And if we can correct them, definitely I think they tolerate statins better. In fact, there is a beautiful study that is a Samson's trial where they say, that these symptoms are basically, it is in anticipation of the side effects that they start complaining, and actually these symptoms do not exist. And, this is more reported when we use in clinical randomized control trials. If you look into the data, the statin-associated symptoms are very less. Yes. When we start using patients in our clinics or in this thing, we see that up to 20% of our patients start complaining of symptoms.
Yeah, Nagmani, there is a question by Dr. Prema. She is asking that sargolem in lipid management, any role?
I did not get the question, ma'am.
Sargolitazar, ma'am, in lipid management, any role?
I am not aware.
Philipsa, she's talking of.
Somebody can answer for that, I think.
Yeah, Shiba, you want to make any comment?
Saroglitazar is a drug which has been, came with the name of Lipaglin, has been used for mixed
Diabetes.
triglyceridemia, most of the times for the patients with NASH, non-alcoholic hepatic steatosis.
Okay.
So has been utilized for Indian kind of proatherogenic dyslipidemia, where we've got more triglycerides. So it has some studies, but I think needs much more robust data. It's used rampantly by the gastroenterologists.
Yeah, thank you very much for the information. I had not heard about it. Anyway, thank you for the information.
Yes,
and
Shashi Rekha
Hema
was-
is, Shashi, please.
This is to Dr. Usha. Madam, have you seen where do you refer your patients for LDL apheresis? Because I've read, but even the Indian reports are very less. How many cases have you been able to do LDL apheresis? Because PCSK inhibition makes a big way in that particular population in children.
Correct. Yeah. So LDL apheresis, it is done in NIMHANS. So we send them for a plasma apheresis. So actually, in the last 15 years, to be frank, we have sent one patient for LDL apheresis. The cost per sitting of LDL apheresis comes close to 30,000 rupees.
Oh.
So we rarely actually get it done, though it's there in literature. PCSK9, as a part of some trial, we could give it to 2 children and they showed a beautiful response. But again, once the trial ended, the LDL, they could not continue and the LDL levels were back to its high levels. So it's a very big challenge to treat, and most of the times we don't do just.
I think it's available even in Manipal Hospital, Shashi Rekha, Old Airport Road. The main
Yes, ma'am. But there are some studies that where in a pregnant women they have done an LDL apheresis and they have kind of reported in the literature. When I did the literature search, I was looking at all these things. Manipal Hospital has done it.
Yes.
But how frequently you get patients who refer to LDL apheresis was my.
It has to be an ongoing process. It is not easy. One session of apheresis
One cannot
solve the problem.
Shashireka, it's a tailor-made for that particular patient, It is not how many patients you get, but for that patient, it is very important.
Yes.
So especially when they are pregnant, you have to be very careful.
We don't get so many pediatric population.
I know.
Especially the LDL, the homozygous and heterozygous don't come to us. So that
in Jaideva, we get lots of them, especially the familial hypercholesteremia, and even the younger generation nowadays, the obesity and then the lifestyle is totally changed. They're all addicted to mobile and hardly playing, and the HDL cholesterol being very low in these children is very, very important risk factor, So we have to change the lifestyle, and we have to have more and more such programs to, bring awareness among the general practitioners also. It is not just the lady cardiologist. And I think this sort of program should be done for all the cardiologists, even the physicians and the pediatricians. So then only we can bring the more and more children with the primary prevention, And thank you very much. We had brilliant talk by Nagamani and Usha, and all the 3 panelists have added. And Shiba, thank you very much for increasing our knowledge. Yeah, any comment?
I just a small comment. There was a publication in ESC 2022 which talks about the metabolome which is altered by the menopausal transition. In fact, that's an N-Chrome study where they studied longitudinally the patients from perimenopause to an early menopause, and they found that using the estrogen kind of estrogen containing menopausal hormonal therapy, there was an improvement not just in the lipid profile in terms of LDL and the kind of LDL and HDL particles, but they anticipated an increase in the metabolome. They talked about the ovarian aging, the chronological aging. It's a beautiful article. I'll share it in our Wincars.
I think you should share.
So I think we have got a long future ahead. There are several other questions regarding the duration of bempedoic recommendations once the level is achieved, ma'am, by Dr. Mohanjit. I think duration of treatment with bempedoic acid recommendations once the desired level has been achieved. That's been asked in the audience. I think once the desired level is achieved, if everyone would agree with me, we can withdraw and maybe reinitiate whenever needed. I think that should be the consensus. No though no definite consensus is there. It's so good to see
And
Vijay
there's
ma'am.
there's one more question. Do you think combination is better than high dose statin? That's a very important question because, one of Dr. Rissam, a very senior cardiologist, he died because of the high statin dose, and then, that may be anecdotal or an isolated, but still, it was an eye opener for all of us. So I think we have to be very careful in giving very high doses of statin.
So, yeah, thank you so much for your inputs and a beautiful smile in everyone out here. And as I hand it over to, before I hand it over to Dr. Sujata for a word of thanks, I can see Hema with all the hard work that she has done enrolling everybody in. So a big
clap to Hema and all the speakers.
To wind up, followed by a vote of thanks by Dr. Sujata. Hema, please.
Well done. Thank you so much, ma'am. Thank you very much, everyone. Everyone was so very cooperative, all the office bearers who trusted me and gave me this responsibility, and everyone whom I interacted with to be a panelist or a speaker or a chairperson. Thank you so much for being so cooperative and joining me in this symposium. Thank you so much.
So I think the Karnataka team has literally rocked. So since you are in such rocking form, we request all of you to contribute. Lakshmi, Hema, Veenu, Shashireka, all please contribute to the journal IJCWD, and then Sheba will be a happy person, and believe me, she'll give you all a party. So
done. And I think we must start a multi-center study regarding the lipid profile, especially in children and youngsters. I think
guys are interested in initiating an investigator-initiated study, or any of you, we are with you guys, and please do it. And I thank Hema and the entire team for this rocking effort. Thank you, one and all. And I thank the technical team for being with us at this hour. Thank you.
Yes,
thank you. Shubharatri to all. God bless you.
Thank you,
ma'am. Thank you so much.
Thanks for the
Good evening, ma'am. Bye.
Thank you. Hi.
Hi, ma'am.
Bye, ma'am. Bye.
Bye.